very unwell, constipation, typhoid, there it is. Yep, good. Yeah, I think last year, I think we just got fever, constipation, and something else. And I think it was typhoid. Yeah. Okay. Dairy, blood, tank water. Yeah, okay. What is it? Okay. So, okay, so just do that. Yeah, sweet. Thanks. So immunocompromised likely, or like essentially sexual contact, bloody diarrhea, Shigella. And so what are your other causes of dysentery again? Chest, so what's C? Campylobacter, what's H? Yeah, E? Entamoeba, and your two S's? Yeah, nice. So if you get bloody diarrhea, just think about your chest. So kindergarten teacher, rotavirus, nice. Okay. Chicken. Okay, and we'll cover loose, watery, voluminous bowel actions. Okay. Bloody diarrhea, trophozoites. Entamoeba, yeah. Okay, and India. So typically a return traveler. Okay. Cool. So those are all your gastro ones. I'll move on to PR bleeding now. So in an OSCE, this is how I don't draw it like this, but I essentially just draw this and I just point to my rectum, not mine, like this rectum. Yeah, anyway, that's what I do. And then this is what I write out. So there's two essentially from each, oh yeah.
Sorry, just jumping back to gastro.
Yeah.
I just want to know, like, poultry was associated with Campylobacter and Salmonella.
Campylobacter and Salmonella, yeah, that's true.
How, I know the answer is usually Salmonella, but like,
yeah.
is there something to differentiate?
Yeah, yeah. So the thing with Campylobacter is that it usually gives you dysentery, whereas with Salmonella it usually gives you watery diarrhea, but it can give you dysentery. So that's so in this question, notice how it's not actually bloody diarrhea. It's just large amounts of voluminous bowel actions with chicken. So that will point you more towards your Salmonella picture. Okay, so PR bleeding, I essentially get these four regions and I write out, okay, so this is probably going to be hemorrhoids or fissures. Affecting this part of the bowel, diverticular disease or IBD. Affecting this part of the bowel, ischemic colitis or dysentery. And affecting this part, colorectal cancer or angiodysplasia. Obviously, you might have a different way of doing it, but that's how I like to structure it, because if they have, if you go into the OSCE and you find out it's fresh blood, then you want to start focusing on these things, like the lower down sort of things. If it's talking about melena, then you want to start thinking about your upper GI causes, okay? So I like to just think about it anatomically. And on the right, this is some important stuff to know for your ENQs. So if you get occult bleeding, so typically they pick it up maybe IDA, so iron deficiency anemia, or they pick it up on an FOBT. The number one cause is actually colorectal cancer. If you get visible bleeding, the number one cause is diverticular disease. And if you're shocked and you get melena, it's probably upper GI. But just remember, because in the question they like to ask, like, what's the most likely thing? And there's a few things that it could be, but just choose the most common one if you can't further narrow it down. So IBD, very similar, UC and Crohn's. UC, superficial inflammation. Crohn's is transmural inflammation. UC, Crohn's, because it's transmural, and your whole bowel wall is affected, if that's the lumen and that's the bowel wall. it can, and the whole thing is inflamed. It can cause, it can essentially cause like this deep sort of ulcer that goes all the way through until it causes a fistula. It can cause the fat around it to sort of bunch up because it's going all the way through. Actually, we'll cover this on the next slide. But in terms of the clinical picture, so you see it typically affects your rectum and goes continually through the bowel. It gives you bloody diarrhea, whereas with Crohn's, it's more so microscopic blood in the poo. And yeah, the rest of it is pretty non-specific, but because Crohn's gives you those fissures, abscesses, because of the whole transmural inflammation, you might expect perianal disease with it. And Crohn's, what might be here? Oh, it is. Okay, I was going to ask what place it most likely affects, but if it affects the terminal ileum, what's going to be malabsorbed? B12. What else might be malabsorbed? It's a bit bile acid, actually, and that can cause a malabsorptive picture as well, because bile acid is needed to digest your fats. Oh, it's here. Oh, anyway. And then UC, PSC, so primary sclerosing cholangitis. That's a buzzword. So this is more like pathology sort of thing. Sort of covered it. Oh yeah, so microscopic stuff. This comes up. So Crohn's disease in a lot of patients will give you a non-caseating granuloma. Does anyone know in pathology what they might call, like what the description of a granuloma might be? Yeah, so this is non-caseating, so it won't have necrosis, but epithelial histocytes, yeah, that's the buzzword, I guess. UC, so this is important. It gives you submucosal abscesses, and it can also give you crypt distortion. Yeah, the main complications. So as we've talked about, fistulization and perforation, and UC can give you toxic megacolon. So we'll go into that a little bit in detail here. So essentially over here, you can see there's loss of haustra, okay, with the left-hand image. And so this is your lead pipe colon that can lead to a toxic megacolon. So this is in fact toxic megacolon. Over here on the right, this is your string sign because of the stricture of the transmural inflammation in Crohn's. And so it can cause this long string over here. There's another similar sign in colorectal cancer, which is called your apple core sign, and we'll cover that later. Yeah, so you want to try and do a colonoscopy when they're not active, when they're not currently in the inflammatory state, and do a biopsy to diagnose it. So UC and Crohn's management is kind of similar in that with the maintenance, if you look from here onwards, you have immunomodulatory, with methotrexate is one of them as well, and biologics. But in terms of UC, you use 5 ASAs as the first line therapy for induction as well as for maintenance, and then the rest is very similar to Crohn's. So for induction, you give PR as well as oral 5-ASA, and the ones you use are mesalazine and sulfasalazine. You can, second line therapy to add on is steroids, and this pretty much follows this now. So steroids and fluids. So if it's severe, because it can give you, it's like a hypercoagulable state, you would consider VTE prophylaxis. Yep, that's the main stuff here. So there's still a question on it. So a young man, pain, bloody mucus, diarrhea, and fever. So it's probably IBD, even though he came back from a holiday in London. So I think there's been a question for us in like a VIA where it was pretty much this stem, but they didn't have the management, and it was like, what's the diagnosis or something? And so the diagnosis is IBD because this is just a red herring, the whole short holiday to London thing. So what would you do for this patient? Pred, yeah. So is this UC or Crohn's most likely? It's most likely UC because of the bloody diarrhea. And so what's first line usually for UC induction? 5 ASAs, which is not here, and that's why you go for Pred. Okay, what about this one? So central abdo pain, distension, nausea, feculent vomiting. What's going on without going on further? So there's an obstruction. So maybe a distal small bowel or a large bowel obstruction. And then he has Crohn's. So what's going on? Stricture. And what do you need to do? Yeah, send them to theatre. Nice. Okay. Okay, celiac disease. Maybe this is something to know for your pathology exam, but HLA-DQ2. And then, so that's on genetic testing. In terms of associations, it's an autoimmune thing, so it's associated with other autoimmune things. It's also associated with IgA deficiency. In terms of presentation, it's like a chronic malabsorption. So you get, other than your diarrhea and stuff, you get loss of weight. In children, you get failure to thrive. So like growth stunting in a sense, and gluteal wasting in children. And you're fatigued because it's chronic and you're not really absorbing a lot of stuff. And this is like a buzzword thing, dermatitis herpetiformis. It's intensely pruritic. So what part of the bowel is most commonly affected in celiac disease? Duodenum. And then what's absorbed in your duodenum, vitamin-wise? Iron. And what's absorbed in your jejunum? Folate. Okay. And then your ileum, as we said before, is B12. That's good. And so it can typically affect other parts of your bowel as well. That's why you can get combined anemias. Complications, because you're not really absorbing that well, especially the fats, you can get osteoporosis as a result of both the chronic disease as well as the vitamin D deficiency. Celiac disease, I think if you do get a OSCE on it, they might like you to be able to say these. Maybe, I don't know, but it's there. And you want to do IgA levels as well, because it's associated with IgA deficiency. These might be low when it shouldn't be. So in terms of pathology, you get the three things. So villus atrophy, crypt hyperplasia, intraepithelial lymphocytes. So in terms of, this is a normal bowel on the left-hand side. Right-hand side, you're supposed to have like your villi like this, but it's not there. So it's villus atrophy, and there's crypt hyperplasia. All of these things down here, and you get if you zoom in a bit closer, you get lymphocytes. You want to consider DEXA because of the osteoporosis risk. Yeah, and the management is there. So bowel obstruction. So in terms of your small and large bowel, the most common cause in the small bowel obstruction is adhesions. So post-operative complication, hernias and neoplasm. So remember the top three causes for both of these. Whereas large bowel is most commonly by far is colorectal cancer. And it's because of that, because that's the most likely cause, it's usually very slow progression of large bowel obstruction. Whereas these ones on the left-hand side, adhesions and hernia, you can imagine that it's much more acute presentation. They typically present in different ways, although this isn't so clear in your EMQs, but just for you to know, in a small bowel obstruction, you typically get pain first and then vomiting and then your distension and constipation. Whereas large bowel obstruction, because it's gradual, you get constipation first and then distension and then your pain and vomiting later. You get hyperactive or increased bowel sounds, whereas if it's ileus, you get no bowel sounds. So that's how you differentiate it. Okay, So essentially on the left-hand side, for both of these, this is small bowel obstruction. This is what position is the patient likely to be in on the left-hand side? Supine, and on this side, that's erect. We don't really do erect anymore, but that's there if you, I guess, get a question on it or get an X-ray and an OSCE on it. So you can see that the bowel in both is dilated, and you can see the plicae circularis going right through. So that's small bowel. On the right-hand side, you can see a step ladder sort of appearance and air fluid levels. And so that's what tells you it's an SBO. In bowel obstruction, there's the 3-6-9 rule. So 3 is for small bowel. If it's 3 centimeters dilated, that's distended. In large bowel, this is large bowel. If it's 6 centimeters dilated, that's distended. If it's cecum, this is not a cecum. If it was pointing that way, then that would be 9 centimeters. So sorry, this is a sigmoid. But anyway, so how you tell with the volvulus, it's not too important, but essentially the volvulus will point towards whether it's cecum or sigmoid. So that's pointing that way, so it's sigmoid. Anyway, yeah, you can see there's haustration, loss of haustrations here. So these will cause your large bowel obstruction. Okay. Large bowel obstruction, we've covered this so much, but ABC, IV resus, analgesia, nasogastric tube decompression, and if they're unresolved within 48, so this is not an emergency unless they're strangulated. And how do you know if they're strangulated? What sign do you get? Might not have covered this. You get peritonitic. So if it's large bowel obstruction with peritonitis, then that's an indication for emergency surgery. Okay. Colorectal cancer, that's your apple core sign there. So usually they like to test this a lot. They get a change in bowel habit. So either from diarrhea to constipation or constipation to diarrhea, and PR bleeding. On the right-hand side, it's usually they present asymptomatically with iron deficiency anemia. On the left-hand side, they'll present with altered bowel habits. If it's in the rectum, then it gives you tenesmus. So what does tenesmus mean? Yeah, a feeling of incomplete defecation after defecation. Commonly, it metastasizes to the liver. Okay, something, yeah, that's important to know. And this is your apple core sign. So, yeah, it looks a bit different to the IBD one, the Crohn's one, where the Crohn's one is the string sign and it's a bit longer. This one is the apple core sign. And I say this because it's come up before. So, colonoscopy, that's something for you to go through in your own time. Ischemic bowel. Okay, so the main thing to know is that for the main risk factors for acute mesenteric ischemia is atrial fibrillation. And then in ischemic colitis, it's an elderly patient with cardiovascular risk factors and they've had a stroke in the past. How you tell the difference clinically is that acute mesenteric ischemia, they say, is like the pain is disproportionate to the clinical signs. So when you sort of palpate them and all of that, they're okay, but they complain of severe abdo pain and they're shocked. Whereas ischemic colitis, there is abdotenderness and there is PR bleeding as well. Oh, you get that in both though. And you typically get an elevated lactate because of the ischemia. Okay, so that's ischemic bowel. Acute appendicitis, this is very classic. I'm sure you guys know it very well, but you get the periumbilical pain migrating down to the riff. Later on, you might get vomiting and diarrhea. Typically, the fever is low-grade fever compared to mesenteric adenitis, which is a high-grade fever. Mesenteric adenitis is inflammation of the lymph nodes in your riff, and it presents very similarly, but you might get a prodromal sort of 30. And the main thing you're worried about is perforation in appendicitis. Diverticular disease. So just some definitions. Diverticular is where you get that hole there. Diverticulosis is the presence of diverticular. And diverticular disease is when you get complications. So you either get inflammation or you get bleeding. So diverticulosis, I'm running out of time, so I might just go over the main stuff. Essentially, they are constipated, and so you want to think about your constipation risk factors, not drinking enough water, and not a lot of fiber. And so in an OSCE, you want to target that, and you want to talk about fiber and constipation and stuff, and they're usually asymptomatic. If you have diverticular bleeding, then this is, as we said before, the most common cause of PR, like visible PR bleeding. And so typically it's painless bleeding of heaps of blood, what looks like heaps of blood, but it's not usually that much. And you don't really get anything else. And so because it's concerning, you might admit them. And in real life, it's hard to really differentiate with the PR bleeding. And so that's why you might consider doing other investigations. But I think that's all you need to know for diverticular bleeding, or the red stuff. Diverticulitis is when you get inflammation, and it's mainly because poo gets stuck in the holes. So it's lift pain, and you get marked tenderness in that quadrant. The other thing for diverticulitis is you give them IV fluids, nil by mouth, and antibiotics. Maybe it comes up in an OSCE or something. And this one. You do a CT abdo to investigate further and to diagnose it. So irritable bowel syndrome, essentially the classic thing you get is alternating diarrhea and constipation. You get bloating, and you get improved pain on defecation. And often in the stem, it's precipitated by anxiety. And you shouldn't have any red flags, okay? And at least in the 4th year thing, we got an OSCE on it in terms of management. So that's there if you want to read it. I don't think it's too important. Angiodysplasia. It's mainly a differential for PR bleeding, but it's asymptomatic. So you can't really ask for it in an OSCE. It's just something to be like, what are your differentials? Oh, I'd consider angiodysplasia. That's the main thing. Okay, so questions. Alternating cycles of diarrhea and constipation the last few months. Mucus. So that's not typical of IBS. You want to start thinking about organic. And he has tenesmus. So what do you think is going on? Colorectal cancer? Yeah, nice. So change in bowel habits, fast onset, mucus and tenesmus. So probably rectal cancer. So lift pain and fever, what is it? Oh wait, it's not a what is it question. What is it anyway? Diverticulitis. So what do you want to do? See? Yeah. So CT abdo, that will give you the diagnosis. And as we said already, antibiotics, fluids, nil orally, and yep. Okay, this one. This is a weird one. So metastatic ovarian cancer. She's had surgery, chemo, and she has 3 days of vomiting. Small bowel obstruction, why? Adhesions. So there's another question where they took out the middle bit, who was originally treated 2 years ago with surgery and chemo. So they took that out, and it was just metastatic ovarian cancer with 3 days of vomiting, and it's still small bowel obstruction. If you look over the slides, under small bowel obstruction. So what are the 3 main causes of small bowel obstruction? Yeah, and under neoplasm, there's primary and secondary. under secondary, I put down there were 2. Did anyone read it? It was really small, but remember this. So the classic one is melanoma, and the other one is ovarian cancer. So ovarian cancer can cause neoplasm in the small bowel, which can cause an SBO. That's so niche, but yeah, it's there for you to know in case you get a question like that. So if they give you like metastatic melanoma or something. Okay. Ischemic stroke, old lady, PR bleeding, generalized abdo pain, elevated lactate. So you want to start thinking about ischemic bowel. What kind of ischemic? Oh, that was sorry. Yep. Okay. What kind of ischemic bowel is it? Chronic. Yeah, this is more likely a chronic type. Sorry, I gave that away. Okay, let's move on. Vomiting, colicky, abdo pain, like random stuff. This is weird. Yeah, so some people are saying gastric outlet obstruction. I'm not too sure on this one. I still put down SBO because I'm assuming they had surgery for appendicitis and they had hernias, but yeah, I don't know about this one. So that's up for debate if you guys want to debate it. But yeah, the thing is like central colicky abdo pain is just so classic of an SBO. Yeah. So diabetes, it can cause gastroparesis. MS, it can cause gut dysmotility. But I don't really get the associations with gastric outlet obstruction. The main causes of gastric outlet obstruction, does anyone know the main causes? Peptic ulcer and cancer. So they're the main ones, I think. Peptic ulcer and cancer. Yeah. So I think it's less likely to be like a dysmotility gut thing. Hernias, nearly at the end. Okay, so hernias, I've put down an approach to, this is an examination approach. I don't think you would get an examination. I don't think so. Maybe you would, who knows? But this more so helps for understanding EMQs anyway. That's why I put it in. So when you see the patient, get them to stand up because that will help the hernias come down a bit and for you to see. And then you want to see 2 things. So do they have a varicocele or a saphenopharynx? Because then I don't really need to consider hernia. A varicocele, it looks like this here, so bag of worms, and saphenopharynx, there's a little lump over your saphenous opening and you get varicose veins down below. So very typical, you'll be able to see it when they stand up, but usually it's only visualized when they stand up. And then if you say, okay, it's probably not those 2, then you want to say, okay, is it inguinal or femoral? So you want to feel, if it's inguinal, that's your C is your inguinal, and your A is your femoral, okay? This is your inguinal canal from B to E, and so the hernias will come out through there, through the B. And then C is your femoral, what's it called? Femoral canal. So what's D and C, or those 2 things here? What's that most likely? Femoral artery and vein. So what's the most lateral thing in this series of stuff? Most lateral is nerve, so navel, so moving laterally to medially, nerve, femoral artery, femoral vein, empty space, so that's your canal, and your lymphatics, just some revision. So if it's above and medial to the pubic tubercle, it's your inguinal. If it's below and lateral, that's your femoral. And then you want to try and reduce it once they lie back down, do it gently. If it's irreducible, then in the question, it will say that it's incarcerated, which is a risk factor for strangulation. So if you think about it, incarceration means you're locked up. Strangulated sounds pretty terrifying, so it's even worse. And so you get persisting pain with strangulation. Tense, tender, irreducible, no cough impulse. So the main thing is tense and tender. and that can lead to bowel obstruction, which is your risk factor for SBO. And then you want to see the scrotum. Is there any lump in the scrotum? If you can get above it, it's most likely a scrotal thing. If you can't get above it, then you want to start thinking about indirect inguinal hernia. So let's, yeah, I've covered this. So I don't think there's too much to know about this. Mainly the fact that direct, it goes through a Hesselbach triangle. So that's medial to your inferior epigastric vessels. Indirect goes through the inguinal canal and out through the superficial inguinal ring. And that's usually because of a patent processus vaginalis. So I have a picture on this. No, I don't. Wait, next one. Yeah, this one. So embryologically, the gubernaculum brings the testes down, and then you have your patent processus vaginalis, which is normal. But then when you grow a bit more, it's supposed to obliterate. And in some patients, it doesn't obliterate. And so if it's narrow, you'll get fluid. If it's big, you'll get an inguinal hernia. So that's how you conceptualize it. Okay. So going to your femoral hernias. The main thing with this is that femoral hernias, it typically presents in women, and it typically presents irreducible. So it's the most common cause of strangulation. So that's important to know. Okay. These are some other differentials. So we've already covered these. So your varicocele and your saphenobarics. In terms of your hydrocele, it's usually fluctuant and you can transilluminate it with a torch underneath. With your hydrocele, it can be idiopathic. It can be from the patent processus vaginalis, but it can also be secondary. So if you have like a torsion, or if you have like an epididymoelchitis, that can cause a secondary hydrocele. And so if it's non-tender and transilluminating, that's definitely hydrocele. If it's tender and transilluminating, you want to start thinking about something underlying. So maybe a torted testicular appendage, or a torted something, or something underlying it. So if you get an option on that, try and look not for the hydrocele, because that's most likely a secondary hydrocele. I think this thing needs more, it's not moving. Hang on, it's moving, sorry. I think there's only 10 minutes left anyway.
Oh, okay, that's fine.
I'll just keep going for this. Yeah, so we're nearly done. Okay, lump in right groin, present all the time. Remember how no, I'll let you guys do it and then we'll talk about it. So what's the most likely diagnosis? Lipoma, yeah. So slipping sign, that's when you try and palpate it and it slips out of your hand, so that's lipoma. So the main thing here is that it's present sitting or lying. So either it's incarcerated or it's not a hernia. And so in this case, it's a lipoma. So the main thing that gives it away is a slipping sign. Scrotal swelling, not reducible, and you can't get above it. Okay, what's the most likely diagnosis? Hydrocele? Yeah, okay. Okay, great. Cool. Groin swelling, that's below and lateral. So what kind of hernia is this? Femoral, yeah. And painful and tender. So what's happened? Strangulated, yeah. Okay. Lump in the right groin below the inguinal ligament, 6 months, and he has varices and disappears when he lies down, very typical. So saphenobarics. Okay, anorectal, and this is it. So we've kind of covered this already. If it's a tenesmus, you want to IBS, but you want to be concerned about a rectal or anal mass. If it's blood mixed into the feces, consider polyps or carcinoma. These are like your red flags, not the most common. And then a note on anal pain. So if that's your dentate line down there, anal transitional zone is right above it. If it's above it, you won't get pain. If it's below it, you'll get pain. A is a perianal hematoma, which is also an external hemorrhoid. B is your anal fissure, most commonly posterior. C is your prolapsing hemorrhoid, and D is a perianal abscess. So this, I'll let you go through in your own time. It's quite a good table. So hemorrhoids, usually chronic constipation and pregnancy, they don't usually give you pain. They might give you discomfort if it's prolapsing a lot, but it shouldn't give you acute anal pain. If it does, it probably is thrombosed, and that they need to come into hospital and they need to get that removed. So typically it gives you painless bleeding unless it's thrombosed. That's the main stuff. Perianal abscess. So perianal abscess is usually a tender lump with fever, and a fistula is usually a complication of this. So the thing that differentiates it is that it'll start discharging. And some risk factors might be Crohn's disease or diabetes and steroid use. So immunosuppression and then the fistulizing stuff. So anal fissures, usually like really intense pain, burning they describe it as, and it's small amounts. And you want to give nitrate ointment for this, and the common side effects are headaches and hypotension. Okay, so postpartum, you're likely to get three things. So the hemorrhoid thrombosis usually happens immediately postpartum. Hemorrhoid prolapse also happens immediately, and anal fissure can happen at any time. So those are some differentials to consider if someone just had a child. So rectal prolapse. So the main thing with this is that if they're elderly, female, and they have constipation, then their rectum might come out like that. And they get incontinence and or constipation and tenesmus because their rectum is there. Cancer. So the main thing that will tell you it's cancer, at least in questions, is the loss of weight. But obviously these things are very important to know. Rectal polyps, it's really strange, but usually it's asymptomatic. Let's just go through some questions and we'll talk about it a bit more in detail. This is just other options, but it's never been an answer, I think. Okay, so follic history of bright PR bleeding and nothing else. So what's the most common cause? Yeah, so you might consider, it could be hemorrhoid, but the most common, most likely, is diverticular disease. Recent onset loose bowel motions, so change in bowel habits, blood, tenesmus, and her mum has cancer of the liver, which she had no surgery for, so maybe metastatic. So what is this? Cancer? Rectal cancer. Okay. This one, because we don't have a lot of time, I think it's very unclear, but we asked Anne Powell from Central. She said it was rectal cancer because of immunosuppression. Anal seepage, lump at the rectum, had lots of children, elderly woman. These are buzzwords for prolapse. Yeah. The anal seepage is like a, what's it called? Overflow incontinence. Okay, nearly there. Burning pain. What? Anal fissure. So in one of the questions, in like 3 of them, they didn't have this sentence. She also noticed a small lump, but in one of them they did. So I think what they're trying to get at is possibly an anal tag, skin tag, that's associated with a fissure, maybe. But yeah, burning pain gives it away. Blood mixed into the stools and tenesmus. Maybe cancer. Yeah, so I was tossing up between cancer and polyps just because I'm like all the other questions with the cancer, they had loss of weight. But I really don't. It's such a strange question because it could be G or J. And 6 weeks postpartum, acute anal pain. Yeah, it could be fissure. So I think it's fissure. You can argue maybe it's thrombosed hemorrhoids, so maybe it's C, but they should make it more clear if they want to get you to say thrombosed hemorrhoids. So I think anal fissure is the most likely. So, okay, we've finished it. There's a few other things I've included at the very end, just because